Hello, and welcome to MRA's soft tissue procedure presentation. My name is Sarah Reed, and I'll be your presenter today. I work with MRA as an outpatient coding auditor, and I've been working in HIM for about 13 years. Really excited to be with you today. We're going to talk about some soft tissue procedures, so think of those that are located in the musculoskeletal section of your CPT book. We'll go over things, we'll start with muscle biopsies, and then we'll go over some soft tissue tumor excisions, so think lipomas for those. We'll talk about those deep INDs for the deep abscesses and hematomas. We'll go over ganglions and trigger fingers. Towards the end, we're going to talk about the definition between primary and secondary repair, and when it's appropriate to choose your code based on those definitions. And then we'll end with cartilage, fascia, and tendon grafting. So muscle biopsies can be performed to discover some diseases that cause muscle pain and weakness. Um, Common sites that you may see your provider biopsying is the biceps or the upper arm area, the deltoid, which is the shoulder area, and the quadriceps or thigh. Your provider can do a percutaneous needle biopsy or also an open incisional technique. Muscle biopsies can help to identify various muscle disorders, such as genetic disorders like muscular dystrophy. Kind of a basic definition for muscular dystrophy is weakness and loss of muscle mass. There's various conditions that fall under this category. For instance, Duchenne's, which is the most common and affects boys more than girls. Duchenne patients may have frequent falls. You may see some muscle pain and stiffness and even growth delays with these patients. Becker, which is similar to Duchenne but progresses at a slower rate, often begins when the patient's a teenager or around their mid 20s. There's other types as well, such as myotonic and FSHD, which are named after their location in the body. Another genetic disorder called Friedreich's ataxia occurs around 5 to 15 years of age in patients. It affects the spinal cord, peripheral nerves, cerebellum function, and the heart. Due to the sites that it's affecting, these patients are going to have some muscle weakness with loss of coordination and balance due to those nervous system damages that they're experiencing. For autoimmune disorders, we'll just talk about myasthenia gravis today. This is a disorder where the ability for muscles and nerves to communicate breaks down. The body actually creates antibodies that are going to either block or destroy muscle receptor sites, which decreases the muscle's ability to receive nerve signals, and that's what's going to lead to their muscle weakness. These patients have some early signs such as eyelid ptosis, diplopia. They're going to experience some arm and leg weakness, including things like speech difficulty, trouble swallowing, and breathing. Often seen in women younger than 40 and men older than 60. For our inflammatory diseases that can be diagnosed with a muscle biopsy, we have things listed here such as polymyositis, which is chronic inflammation and weakness, and dermatomyositis, which is muscle weakness with a skin rash. And these patients are going to have a red or purple colored skin rash, usually on their face, maybe their back and chest, and over their joints, such as knees and elbows. We can also determine if a patient has a disease of connective tissue and blood vessels with a muscle biopsy. Polyarteritis nodosa, is inflammation of the blood vessels. Symptoms will be related to the body area involved, such as muscle pain or chest pain when the heart is affected. And when nerves are affected, the patients are going to have some numbness or loss of strength. So, a brief definition would be vasculitis, which is injuring the nerves, heart, joints, and intestines. We can also determine If a patient has an infection, such as trichinosis or toxoplasmosis, um, these, in both of these cases, lab tests are usually sufficient enough for a diagnosis, but your provider can do a muscle biopsy if he deems it necessary. For our open biopsy, we have two codes available. During the muscle biopsy, your physician is going to incise the skin down to the muscle and then excise a tissue sample to send off to pathology for analysis. If your provider performs a superficial biopsy by open method, then you will assign CPT 20200. If your provider does a deep muscle biopsy, then you'll refer to 20205. Your provider documentation should let you know whether that biopsy was superficial or deep. It's not up to us as coders to decide that. We really do need the provider's documentation to let us know so that we can assign the most appropriate code. If that documentation is missing, we will need to query just to make sure that we're not assuming and assigning an incorrect code possibly. When your provider excises more than one muscle as biopsy, then you're going to assign one code for each excision. So if he does a muscle biopsy in the deltoid and then does another one in the quadriceps, you'll want to make sure that you're capturing both of those biopsies with separate codes. For our closed biopsy, this is a percutaneous biopsy where the physician will use a bore needle to collect the tissue sample. We just have one code available for this method of biopsy. It's 20206, and it's biopsy muscle by percutaneous needle. If your provider does an FNA or fine needle aspiration biopsy rather than that larger bore needle biopsy to collect that tissue sample, then you're going to want to refer back to the FNA biopsy codes, which are located in the integumentary section of CPT, and you'll find those at 10004 through 10021. Next, we'll move right along into our soft tissue tumors. When talking about soft tissue tumors, we're talking about those lesions that are located in the deeper tissues below the level of the skin. So think subcutaneous, fascia, subfascial, and intramuscular for location. For benign soft tissue tumors, we have some examples here. Lipomas, which are fatty, non-cancerous tumors. These are slow growers that are often removed if they are causing pain or discomfort. Angiolipomas are a mix of fat and blood vessels. Fibromas are located in fibrous connective tissue and can be the result of an injury or even just a local irritation. You may also see desmoid tumors documented for these soft tissue tumor removals, and these are benign connective tissue tumors. For malignant, we're talking about things such as sarcoma, which is a soft tissue cancer, leiomyosarcoma, which are located in smooth muscle tissue, liposarcomas, these are malignant fat tissue tumors. And we also have things such as malignant fibrous histiocytomas. These can be found in soft tissue, but they can also form in bone. Common sites for these histiocytomas are legs, arms, back, or abdomen. And of course, these lists are not all inclusive, but just to kind of give you an idea of some of the things that you may be seeing for these removals. So for the benign excision, our code selection will be by location and then by depth. So is your provider subcutaneous or is he in the subfascial intramuscular area? And then we'll also need to know the size, and that will be the diameter plus the margin. You'll report complex repair separately, but if your provider just needs to perform a simple or intermediate repair, those are included, so you will not report those separately. You can additionally code vessel exploration or neuroplasty if that's performed. And just a word of caution here, we're talking about musculoskeletal lesion excision. So if your provider is removing a lesion that is of cutaneous origin, then you're going to want to refer back to the integumentary section of CPT and look at those codes for benign excision 11400 through 11446. For radical resection of soft tissue tumors, we're talking about malignant and or aggressive benign connective tissue tumors. Your code selection will again be by location in the body. You'll notice that there's no depth qualifier with these codes due to these tumors requiring fascial resection. For the size, you're going to look at diameter and margin again. And you should be seeing in your documentation excision of a wide margin around the tumor. The provider is going to be removing the tumor itself and then a rim of healthy tissue to excise surrounding tissue that may be affected by the spread of the tumor. So that you'll see in your documentation that this is a more extensive procedure than just for your benign removals. You're going to report complex repair separately. If your provider has to do an adjacent tissue transfer or some grafting, you can also capture those procedures in addition to your radical resection codes. And just like your benign, if you have vessel exploration or neuroplasty, you can also assign additional code for that. And again, if this excision happens to be a lesion of cutaneous origin, then you're going to refer back to the integumentary section again and not use the deeper soft tissue tumor code. So really important to know what kind of lesion your provider is removing, the level of tissue that he's removing it from, and then paying attention to those additional details to see if more than one code is required. As we talked about, our code selection is based on the body area of where that tumor is being removed, and there's quite a few codes available. So everything from head and neck and chest to shoulder and upper arm. If your provider is removing tumors from the shoulder or the upper arm and elbow area, or even the forearm and wrist, don't forget those right and left modifiers if appropriate. And as you can see, we have more hands and fingers, pelvis and hip, etc. So again, with these bilateral areas like arms and legs, hands and feet, we can use that right and left modifier as applicable. So I kind of want to break down some of the different definitions that go with these codes. So we talked about simple and intermediate repair being included, but that we can code that complex repair additionally if it's required to close that excision site. So let's talk exactly about what complex repair is and what it entails and what's included in that kind of thing. So um, again, complex repair codes are assigned when the requirements for intermediate repair are met in addition to specific complex repair criteria. And you'll see if you, I use the AMA CPT Professional Edition, and it has a lot of instructional notes. Your book may or may not have those. If it doesn't, you can look into your CPT assistant, but these definitions come from CPT directly. So in order to code complex repair, we have to meet the definition of intermediate repair first. So let's look at what that is. Intermediate repair is the layered closure of one or more deep layers of subcutaneous tissue and non-muscle fascia. Of course, that includes the epidermis and dermis. Intermediate repair also includes limited undermining, and it also includes single layer closure of a heavily contaminated wound that requires extensive cleaning or removal of debris. So that is our intermediate repair definition. Now we're going to talk about complex repair. So in order to code complex repair, we first have to meet the requirements for intermediate repair, and then we have to meet at least one of the following. So exposure of bone, cartilage, tendon, or named vascular structure, or debridement of wound edges, such as you would see in traumatic laceration or avulsions, extensive undermining. So limited undermining is included with intermediate repair, but for complex repair, we have to see extensive undermining. In complex repair also includes repair which involves the free margins of the helical rim, the vermilion border, or the nostril rim. And complex repair also includes placement of retention sutures. So let's look a little bit closer at some of these definitions. So undermining. Undermining is the act of mobilizing soft tissue around a defect to assist in wound closure. Undermining allows the skin edges to be lifted and then brought together with gentle traction. So this is a dissection of skin from underlying tissue by scissors or scalpel which frees those wound edges, decreasing that tension and allowing the provider to move that tissue into a better location for closure. The good thing about undermining is we get some faster wound healing. We're going to have some less scar formation. And because we're reducing that wound tension, we're going to have less instance of wound adhesions. Some cons, we may have some small vessels that are cut, which will cause decreased wound perfusion. And also sometimes nerves can be cut, which can cause that temporary feeling of numbness in the area. So again, limited is included with intermediate repairs, but if your provider documents that it's extensive undermining, then it will lead you to that complex repair, meeting that criteria for that definition. Your provider needs to let you know whether it's limited or extensive. So again, if your provider doesn't tell you or you're just not totally sure, you may need to just have a query to get some clarification before code assignment. Our complex repair codes include repair of the vermilion border, which is the margin between the lip and adjacent skin. Also includes the nostril rim, which is that entry to the nose, that skin that surrounds that entry, and also the helical rim, which is the outer rim of the ear. When your provider uses retention sutures, complex repair code can also be assigned. So retention sutures are used in high tension wound closures. They support that primary repair. They help relieve tension and reduce that risk of wound adhesions, again, that separation that can occur. And for documentation of retention suture use, you'll see that these are non-absorbable, they're heavy gauge material of a large caliber, and they're used in conjunction with a device such as a bolster, a bridge, or elastic tubing. Adjacent tissue transfers can also be coded additionally when performed, and these codes are located in 14000 through 14302. Adjacent tissue transfers are creation of a tissue flap, which frees the skin and the underlying tissue, which can then be moved into place to close a defect. The base of the tissue flap will remain connected to its natural blood supply, so it's more of a rotation than just a full graft or removal of skin to one place to another. So different kinds of tissue transfers exist, of course. We've seen things like Z-plasty, W-plasty, etc. Z-plasty can also be called a transposition flap. It's a method of creating a flap that borrows from an area of skin laxity to correct a defect that has some tension. You'll also may see things such as rotation flap. This method closes a defect by rotation of skin around a pivot point. I think most common we see advancement flaps, and this is moving of tissue in a straight line stretching over the defect. Some caution or note of caution from our CPT book telling us undermining of adjacent tissue to achieve closure without additional incisions is not an adjacent tissue transfer. So if your provider is doing some kind of undermining to move that skin, our CPT instruction tells us to look back at those complex repair codes. So adjacent tissue transfer, you're going to see additional incisions, you're going to see some rotation of skin or movement of skin in some way, some kind of a flap to correct those areas that need closure. So as we mentioned earlier, the soft tissue code, excision codes, we're talking about tumors that are located in the subcutaneous and lower soft tissues. If your lesion has an origin of dermal tissue, then you'll want to use a code from the integumentary section. So for instance, sebaceous cysts. These are skin lesions, and sometimes they're very large and they can expand into deeper tissue, such as subcutaneous fatty tissue. But because their origin is skin, we are going to assign a code from the integumentary section when those are excised, even when they're large and expanding into that deeper tissue. And there's a reference here for you, CPT Assistant, April 2010, Volume 20, Issue 4, page 3. Hilar cyst is another type of dermal lesion that you will want to assign a code from the integumentary section instead of a soft tissue tumor code, because again, their origin is from the dermis, and so they are considered integumentary lesions, and you will assign an integumentary code for that. And we also have another CPT assistant here. This one is from October 2010, page 9. I think another frustrating area are the soft tissue tumors of the axilla, and so I thought we'd kind of talk about this for a minute. The axillary region encompasses the area near or under the armpit and connects to the shoulder. And so we're going to see varied size and shape depending on your patient. And this axillary region borders like a pyramid, if you can kind of picture it. It includes the thorax, the upper arm, and the shoulder. So it's very important to identify not only the type of lesion, right? We have to know if it's from skin, it's a dermal lesion, or if it's a soft tissue tumor. But we also need to know exactly where it's located. If your provider documents axilla as the area of excision, look in the body of your procedure note. Is he talking about the thorax region? Is he in the upper arm? Maybe he's in the shoulder area. As you can see, we have quite a few codes available depending on where your provider actually is. So if your provider isn't very clear or you can't really tell, you may need to query. But again, just kind of a word of caution with the excision of these axilla tumors. There is a coding clinic for HCPCS first quarter 2017, page 5, that talks about this situation that could help you if you get stuck. So just something to be aware of. So we have a little coding practice here just to kind of put all of our thoughts together. We have a 26-year-old patient who's presenting for excision of a 2.6 centimeter soft tissue tumor. Location is right forehead. Provider makes an incision through the skin and subq down to the mass. The frontalis muscle is incised to enable the dissection of the tumor from surrounding structures and fascial attachments. The mass is removed, neurovascular structures intact, incision closed, patient taken to recovery. We have our pathology report diagnosis, which is lipoma. And remember, those pathology reports for outpatient services, pathologists are doctors, so we can use their documentation for diagnosis reporting. And oftentimes, if our provider is just not sure, the pathology report is where we want to be. So it's a good tool to have with your coding. So what do we know? We know we have our size, we have 2.6 centimeters. We have location on the body, which is right forehead. He did go through skin and subcutaneous tissue, but he also had to go down through the muscle. So we're going to be at intramuscular for CPT code assignment. For this coding practice, we'll assign diagnosis code D17.0, which is benign lipoma, head, face, and neck. And for CPT, we'll assign 21014, excision, tumor, soft tissue of face and scalp, subfascial, because again, he had to go through that muscle, and 2 centimeters or greater. Now we're going to move into some incision and drainage type procedures. So incision and drainage can be performed for different conditions, such as abscess, and these are bacterial infections. They could be infected hair follicles. Your patient could be having a foreign body reaction that's causing the abscess. Your provider might also be incising and draining a bursitis. Bursitis can be aseptic, which is a non-infectious type, can occur with some soft tissue injuries. Bursitis can also be infectious or septic. This occurs when the bacteria enters the body through a cut or even something like an insect bite. Bursitis occurs more frequently in patients with inflammatory arthritis, such as rheumatoid arthritis, or some patients that may have a weakened immune system. Incision and drainage can also treat things such as hematomas. Hematomas can be caused by injury, medical procedures. Sometimes your patient will have a post-op hematoma. Anticoagulant use can raise the chance of that happening. IND can also treat tenosynovitis, which is inflammation of the tendon sheath lining. Tenosynovitis can be infectious or non-infectious. For our infectious, we're talking about things such as pyogenic or bacterial. Non-infectious tenosynovitis can occur from strain injuries, maybe overuse injuries. Our patients that have rheumatoid arthritis may have an increased instance of this. Also, patients that have things like scleroderma, dequare veins, medication use such as statins, all kind of contribute to the probability of that occurring. For incision and drainage of deep abscess and hematoma, codes are indexed by the body area treated, so similar to what we were talking about earlier. We have quite a few codes available, everything from forearm and wrist to the neck and thorax, lumbar sacral region. They're kind of easy to index if you go by body site in your index. Not really sure, different encoders go different ways, but just kind of keeping in mind that you can find the IND by body area treated might help you find the code that you're looking for. If your provider is draining an abscess within the breast and you're looking for mastotomy with that deep abscess drainage, you're actually going to be looking in the integumentary section rather than the musculoskeletal, and it will refer you to code 19020. And you can add that modifier right or left on there if you need it. If your provider is not in the deep tissue and he's incising and draining an skin or subcutaneous abscess or hematoma, then you're going to, again, go back to those integumentary section codes. So location is really important. Depth is really important. Make sure that you know where you're at so that you can pick that appropriate code. Similar to IND of abscess and hematomas, IND of bursitis can also be indexed by body area treated. We have codes available in ankle, arm, foot, hip, leg. You can kind of see all the different options. Again, looking in that index under body area will get you to where you want to be. If your provider performs an aspiration to treat bursitis, this will be done by arthrocentesis. It's a percutaneous procedure. And these codes are selected by the size of the joint or bursa. So if your provider's in fingers or toes, you'll pick the small joint arthrocentesis code. If we're wrist and elbow and ankle, we'll be at intermediate joint, and shoulder, hips, and knees are considered your larger joints for code selection. And these codes for arthrocentesis also have a additional qualifier. Was it performed with or without ultrasound imaging guidance? Before you pick a code for with imaging guidance, you need to make sure that you have that permanent recording and reporting in your record. If you do not, then you will use the without ultrasound imaging guidance instead. In the references for this slide deck, there is a reference specific to this. So just make sure that your documentation is supportive before you pick that final code. Looks like we have another coding practice. We have a 65-year-old man with rheumatoid arthritis presenting to the emergency department. He has painful swelling of the left knee. Provider performs an open IND of the knee and sends the collected fluid to the lab for analysis. The lab finds that there's no infection and provider diagnoses rheumatoid bursitis. What diagnosis and CPT code would you assign? We'll assign diagnosis code M06.262 for rheumatoid bursitis, left knee. And for the IND, we'll assign 27301, which is IND of the bursa, thigh or knee region, and we'll add that modifier LT for the left knee. Our next section will be on ganglion cysts. Ganglion cysts are found in lining tendons or in joint capsules. They're more common in women, occurring typically between the ages of 20 and 40. Commonly located in the wrists, hands, ankles, and feet. They can be super painful when they're pressing on a nerve and can be associated with numbness or tingling. In some cases, depending on where they're located and how large they may be, they can impair some joint movement. They do happen to occur more often in patients that have arthritis, or maybe patients that have had a joint or tendon injury. Treatments can be super basic: pain relievers, splinter brace. If those aren't helping, your provider may do an aspiration or excision. Even with removal, sometimes these ganglions will recur in the same location, so it's not a one and done situation in some cases. If they aren't causing any pain or joint movement, impairing problems, then your provider probably will just not necessarily remove them, but if they are causing some discomfort and pain, they usually are removed. So here's some examples of codes which address ganglions. We have CPT 26160, which is excision of lesion of tendon sheath or joint capsule, hand or finger. We also have open codes for the wrist, 25111, which is wrist primary. If that ganglion recurs, we also have a code for recurrent under wrist, 25112. There's additional codes available for excision of ganglions of the knee, the leg and ankle, foot and toes. And for these codes, we can append those modifiers right, left, 50 for bilateral. If they're toes, we can use T1 through T9 or TA. We also have a code for percutaneous, which is CPT 20612, and this is aspiration and or injection of ganglion cysts, any location. So the aspiration is done for drainage. Your provider can inject medication such as a steroid for pain relief, size reduction, and reducing that risk of recurrence. So if your provider is treating one ganglion and he's aspirating and injecting, you're just going to assign the code one time. You'll see that in this code descriptor, you have the cyst with the parentheses S. So this includes multiple cysts. So single or multiple, and it includes both aspiration and or injection. So gouty tophi, what is gouty tophi? Gouty tophi is an accumulation of uric acid crystals in or around a joint capsule. A question was posed to Coding Clinic for HCPCS. How is the excision of gouty tophi coded? Do we code excision of a lesion or excision of a tumor? And Coding Clinic responded, second quarter 2017, page 3, stating that the correct code for excisional debridement of gouty tophi of the finger is 26160, excision of lesion of tendon sheath or joint capsule, hand or finger. And also goes on to further state that it would be incorrect to assign a CPT code for excision of a tumor. Well, going back to our initial definition, gouty tophi is an accumulation of uric acid crystals in or around a joint capsule. And as you'll see with CPT 26160, excision of lesion of sheath or joint capsule. So that meets our definition of what gouty tophi is, and it supports our code assignment. Next up, some trigger fingers. Trigger fingers can also be called stenosing tenosynovitis. It's a condition that causes your finger to catch or lock when bent. It can be caused by things such as repetitive grip, tendon sheath injuries. It's more common in patients with rheumatoid arthritis, gout, and even diabetic patients may have this more commonly. Treatments can be simple or more extensive, so anything from NSAIDs, splinting, some stretching exercises, and hand therapy. Your provider could do a steroid injection. When these things don't help, then surgery may be indicated. So a little bit about trigger fingers and what's happening anatomically. So if you can kind of picture a healthy finger tendon glides smoothly through its tendon sheath. The tendon sheath is a tunnel made up of connective tissue, which is both fibrous and synovial, which protects the tendon and keeps it lubricated. When a tendon is injured or diseased, it can become inflamed, swollen, and irritated. This causes reduced ability for the tendon to move smoothly through that tendon sheath. So if the condition is prolonged, your patient can also get some scar tissue and some thickening that can occur. So trigger finger injections, we talked about this on a previous slide. Your provider can do injections or can do a surgery if needed. For the injection procedure, your physician's going to locate the injection site by feel, or they can use some radiological guidance. The provider will insert a needle into the tendon sheath and then inject the medication. For this, we have CPT 20550, which is injection or injections, single tendon sheath or ligament. For this reporting, you will report once for a single or multiple injections to the same tendon sheath, because we have that injections apostrophe S. If we're in the same site and your provider's doing multiple injections, we'll just code the code once. If he's just doing one injection, we'll just code the code once. If your provider happens to inject more than one tendon sheath, so different locations, then you can report multiple units of 20550. So really pay attention to that documentation and the location of where your provider is injecting. And with these codes, we can also use that right and left modifier or 50 for bilateral if applicable. In the open procedure, your provider is going to make a lengthwise incision into the tendon sheath. Remember that tendon sheath is the tunnel that tendon is passing through. So by incising the sheath, the tension's released, which allows the tendon to move more freely. For this procedure, we have CPT 26055, which is tendon sheath incision. We're going to code it per finger treated, and we can add those modifiers as applicable, right, left 50, F1 through F9 or FA for our finger modifiers. In the percutaneous method, your physician will insert a needle into the tissue around the affected tendon, which will and breaks apart the areas of constriction in the tendon sheath until he can achieve that fluid motion again. So again, he's breaking apart areas of constriction in the tendon sheath, not the tendon. So for this code, we're going to actually have to assign an unlisted at the moment because we don't have a listed code. You can assign CPT 26989, unlisted procedure, hands or fingers. If it's performed with ultrasound guidance and you're responsible for reporting that code, maybe a prophy situation, you can assign that additionally. Most facilities have that charge base, so you won't need to worry about it. Have a little caution when you're looking for the percutaneous code. There is a code that's close. It's CPT 26060, which is tenotomy percutaneous. But in our case, the provider is treating that tendon sheath instead of the tendon. So the tenotomy code isn't appropriate. Tenotomy means surgical cutting of a tendon. So that's why we can't assign that code. And it kind of leads us back to that unlisted. As promised, we're going to talk about the definition between primary and secondary repair. So in certain code sets, you'll see a choice between primary and secondary repair. Primary repair is selected for repairs of an acute condition or the initial repair that's being performed. Secondary repair signifies that the condition is chronic, so of a degenerative nature, or that is a secondary or subsequent surgery is being performed. When that subsequent surgery is being performed, it could be due to a failure of the primary repair. Maybe the patient actually re-ruptured or re-teared that tendon. That's another reason that secondary repair would be chosen. Secondary repair may require a reconstruction with a need of tissue grafts. So it's a little more extensive than kind of an end-to-end repair that you're going to see in the primary repair. Today, specifically, we're going to talk about the Achilles tendon and the various CPT codes available as an example of primary versus secondary. So the Achilles tendon, also sometimes referred to as the calcanean tendon, is located in the back of the leg, attaches the calf muscles to the calcaneus. It's the largest tendon in the body with the ability to hold 4 times the stress of a person's body weight. It's vital for walking, running, and jumping. And this flexor tendon is what allows you to stand up on your toes. So very helpful and important tendon in your body. The Achilles tendon is most commonly ruptured tendon in the body. Various injuries and conditions can affect the Achilles. Injuries can occur with that rapid stop and go movements, something that you may see in sports activities such as tennis or soccer. It can also be injured from a fall. It can become weak with age or lack of use, which will making an injury more likely or more able to happen. The use of medications such as fluoroquinolones or steroids can also increase your risk of an Achilles tendon tear. Patients who have congenital conditions such as flat feet or maybe a high foot arch or a leg length discrepancy can also have an increased risk of tearing the Achilles tendon. So various things we've talked about: injury, it could also be a degenerative condition, tendonitis, bursitis, gout, arthritis. So multiple things can cause Achilles tendon um, tears. So depending on your documentation and the reason for repair will help you to determine your code choice. In a primary repair, your physician's going to incise tissue over the tendon, debride the edges, and repair with sutures. If a graft is required, a fascial graft via a separate incision is obtained and incorporated into the repair with fixation such as a screw. For our primary repair, we have available CPT 27650, which is repair primary open or percutaneous ruptured Achilles tendon. If your provider has to go and get a graft to help with the repair, then we're going to assign 27652, which is repair primary open or percutaneous with graft. And you'll see in the code descriptor that that includes obtaining the graft, so you won't assign an additional code for getting the graft. You'll just use the one combination code. Again, we can use those laterality modifiers, right or left. If your provider is performing a bilateral repair, then modifier 50. In our example here, we're talking about the incisional method, but as you can see in our code descriptor, it also includes percutaneous. When a percutaneous repair is performed, your provider is going to make multiple stab incisions in the tendon and then passing sutures to repair the tendon, which are then tied off, cut, and pushed into the subcutaneous tissue. So it's kind of like a mini open in a way. But again, open or percutaneous, both included in 27650 and 52. For our secondary repair, the procedure is going to be a little more extensive. Your physician may need to debride significant scar tissue, or you may see some calcification debridement. The calcifications can be created by the chronicity of the condition. CPT 27654 represents our secondary repair. So repair secondary Achilles tendon with or without graft. So either way, we're just going to assign the one code since grafting is included when performed. And again, modifier right, left, or 50 as applicable. We have a really helpful CPT assistant from June 2020. The question was posed, does secondary repair code 27654 mean the Achilles tendon had a previous tear, or does it mean it was previously repaired? So CPT assistant is going to clarify a bit for us here, stating that primary repair is a direct surgical repair like an end-to-end repair, where secondary repair involves grafts, flaps, transfers, or more complex repair methods. CPT 27654, which is our repair secondary, can be coded for a prior chronic tear and or a previous repair, whereas 27650, repair primary, is reported for immediate acute repair. The CPT assistant goes on to say that CPT 27654, which is our repair secondary, should be reported for the type of repair and not necessarily the order of when the repair was performed. So if you have a degenerative tear, you may be looking at that secondary repair code. I highly recommend looking at this full CPT assistant from June 2020, page 14. It has a much more lengthy explanation and can be really helpful with your coding. And to wrap up for today, we're going to go over some cartilage, fascia, and tendon grafts. Specifically, we're talking about autografting procedures. We do want to make sure that we're coding tissue grafts when obtained through a separate incision. We do not want to code them separately when they're included in the code descriptor for another procedure that's being performed. We want to select our code based on tissue type, harvested? Is it skin, bone, nerves, tendon, fascia, etc.? And we also want to make sure that we're paying close attention to our CC IDETs and also reading those full CPT code descriptors to make sure that we're not overcoding. Cartilage grafts are used in reconstruction procedures and cosmetic procedures such as rhinoplasty. We have a couple different options available. CPT 20910, cartilage graft costochondral. This is a rib graft. It's typically used in facial reconstruction. 20912, cartilage graft, nasal septum. You may see this documented as a spreader graft, a nasal alar batten graft, or you may see them used in collapsed nasal valve repair. CPT 21235, which is graft ear cartilage autogenous, nose or ear, includes obtaining the graft. For this code, the graft is going to be harvested from the ear and then used to repair the nose or the ear. Another type of graft is the fascia lata graft. This fascia lata is actually the deep fascia of the thigh. It surrounds the thigh muscles and it's a strong tissue which varies in thickness from hip to knee. They're used for a number of different reasons. These grafts can be used to repair recurrent pelvic prolapse. You may see them in your rotator cuff repairs. They can also be used in reconstruction of orbital floor following maxillectomy, and even to correct things such as congenital ptosis. We have two codes for fascia lata grafts, stripper and then a complex incisional. So for our first code here is the stripper method, CPT 20920, fascia lata graft by stripper. In your documentation, you may see something similar to this. Provider makes a small incision and places a suture in the proximal fascia to assist in threading the stripper. The stripper is then inserted and the fascia is pulled through the stripper. The cutting mechanism of the stripper is then engaged, cutting the desired length of fascia, which is then removed. And your provider can remove one strip, he can do multiple strips, whatever is needed. For our complex or sheet, we'll be using CPT 20922. In this case, the provider will incise the skin down to subcutaneous tissue, exposing that thick band of connective tissue, or fascia lata. A flap of fascia is elevated from the underlying muscle and then removed in that sheet instead of a strip, and then used for grafting. For our tendon grafts, keeping in mind that tendons connect muscle to bone, ligaments are the bone to bone, but our tendons are connecting the muscle to bone. They can become torn or damaged, and when this happens, they may require a tendon graft for repair when that tendon doesn't have enough viable tissue for a direct repair. Kind of like in our Achilles tendon, with that acute injury, the provider could suture those tendons back together, but in that more degenerative breakdown of the tendon, he really needed some more complex repair methods with grafting and those kinds of things. So same thing with our tendon grafting. Sometimes that provider is going to need some graft material in order to repair the tendon properly. For tendon grafting, we're looking for documentation that the tendon is harvested from a different site through a separate incision. And we also need to really make sure that that grafting is not already included in a CPT code for the primary procedure. So when those things are met, we have the different site, separate incision, grafting is not already included, then we can, in some cases, assign that additional code. Our example here is CPT 20924, which is tendon graft from a distance. For this code, you're going to see that the tendon is being harvested and removed from one place before being placed in a new site. So this code is not for harvest of a local tendon acquired from the same incision or a counter incision or an accessory incision, such as you may see being performed during a wrist arthroplasty procedure. As the code descriptor for 20924 states, it must be from a distance. So just make sure that your criteria is met, watch those CCI edits, and make sure you're capturing these additionally when required. To wrap up our presentation today, we have one more coding practice. Patient has an incisional hernia and is going to present for repair. The provider is going to perform an open hernia repair, which he noted required reinforcement with a fascia lata graft. The patient's left thigh was prepped and a fascia lata sheet was harvested for grafting. The graft was placed as an onlay graft, overlapping the anterior rectus fascia defect. Incisional hernia repair was completed and thigh wound was closed. In this case, what diagnosis and CPT code would you assign? We'll assign diagnosis K43.2, incisional hernia without obstruction or gangrene. We're going to capture our hernia repair, 49560, repair initial incisional ventral hernia reducible, and we'll capture that fascia lata graft additionally, 20922, and we'll select the code for complex or sheet. And that wraps us up for today. Thank you so much for sticking with me. A few thoughts to take with you as you leave. Documentation is key. We really have to look at those details in the body of our op and procedure notes. If you're just not sure or the provider didn't tell you, maybe he didn't know he needed to tell you, just ask, put out a query, get that clarification, make sure that your code assignment's being supported. Remember that your pathologist is a physician, and so that documentation is codable documentation in the outpatient world. Sometimes we're going to get that more definitive diagnosis and maybe even some really good specificity. So make sure you're using those path reports when they're available. Anatomy charts. I find anatomy charts to be so very helpful, especially when you're doing grafting or other kind of tendon procedures. Being able to picture exactly where your physician is can really help you get down to that most appropriate CPT code in some cases. Make sure you're reading those full CPT code descriptors, things for what's included and what's not. Make sure your documentation is supportive. In some cases, you may need to use an unlisted code. Remember, we can't code something that's close to or almost the right code. If we don't have a code available, we are told to use that unlisted. So really look in your book, see if you can find that code. If not, don't be afraid of those unlisted codes. They're there to help you when you need them. And happy coding, everybody. I hope this presentation was helpful or maybe just a really good refresh for you, and hope you have a great rest of your day.